Well, let's go ahead and call this forum from Health Caucus together. Welcome to everyone who's here today. Welcome to all who are watching on the internet. And I would remind those who are watching the live stream of this that your questions can be tweeted to Health Caucus, and they will be included in the question and answer period. We have two very informed and informative panelists today, and we're going to hear from them in just a moment. And then, as always, there will be an opportunity for questions. I would ask, as we always do at Health Caucus, for you to identify yourself, and if you're with a news organization, tell us which organization you're with, or if you're here from a member's office, just let us know that as well. And we'll be happy to take your questions. The issue of what will happen at the state level as we watch the Affordable Care Act go through its implementation, and also we watch some of the challenges that are coming to the Affordable Care Act in the courts, leaves the states in a tough position. And in fact, we heard in this very room from Governor Herbert from Utah in February or March of this year, when he talked about how he was building his own state exchange in Utah. Then the Affordable Care Act came along, and he literally did not know what to do. He said he felt like he was walking on shifting sands. Well, unfortunately, the landscape has gotten even more rocky or less stable in the months that have followed since then. So perhaps today with this forum we can at least provide a little stability and give people an idea of some of the things that they might expect, regardless of what happens with the implementation of the Affordable Care Act. Today we're going to specifically talk about state efforts for helping the uninsured. And we're all aware of the costs. Really, we're all pretty conversant with the numbers that have been out. In fact, both sides in the presidential election in 2008 talked about those numbers. And the number of people have increased in the last 10 years, going from 19% of the population, or now at 19% of the population, up from 16% in 2007. And the thing is, most people who are uninsured understand that they need health insurance, that it would be a benefit to them, but most are concerned about the cost, and some, quite frankly, find barriers that they just cannot access or do not know how to access health insurance if it's not provided by an employer. The research has found the main reason that people are uninsured and remain uninsured is because of the cost rather than the lack of desire to have the coverage. Now, under the Affordable Care Act, individuals will be required to have health insurance, with an exception if no affordable premium is available. However, this, in combination with those who opt out of the individual mandate and instead pay the penalty, will mean we will still have an uninsured population in this country. The uninsured pay for about a third of their care out of pocket, $30 billion in 2008. Unfortunately, the remaining costs of the care, the uncompensated costs, amount to about $57 billion that same year. And about 3/4 was paid by federal, state, and local funds appropriated for care of the uninsured. Hospitals incur 60% of the cost of uncompensated care because of the high cost of medical needs requiring hospitalization, despite the fact that physicians and community clinics see more uninsured patients. In addition, being uninsured leaves individuals at an increased risk of actually amassing unaffordable medical bills. Uninsured adults are 3 times as likely as insured to have been unable to pay for their basic necessities, such as food and housing, due to medical bills. It is reasons such as these as we urge the uninsured population to find affordable coverage. And here's the good news, and what we're going to hear today. It is there. It is available. It's a question of accessing it and a question of knowing where to go and who to ask. Joining us today are 2 experts on this issue who have looked into innovative ways that the states are helping their uninsured populations find affordable coverage. First, Mr. Phil Leberts, known in the industry for being a passionate broker advocate, committed to reframing the issues affecting the brokerage community. In 2004, he founded the Foundation for Health Coverage Education, a nonprofit organization with the mission to simplify public and private health insurance eligibility in order to help more people access coverage. His input on the healthcare debate, the uninsured, and group health trends are featured regularly in numerous healthcare publications, including the Wall Street Journal, ABC News, the Washington Post, and CNN. Peggy Tithe, a partner in the Washington office. Peggy specializes in legislative and regulatory matters and has significant expertise working with physicians, hospitals, patient groups on issues such as Medicare payment systems, also I might add, working with members of Congress, direct graduate medical education, nursing education, pay for performance initiatives, liability reform, patient safety, and genetic non-discrimination. So we're very fortunate to have both of these panelists here today. I look forward to what they have to share. And as always, for those of you who are watching, if you know of someone who would have benefited from watching this exchange today, but unfortunately missed it, it will be archived in perpetuity at healthcaucus.org. Peggy, why don't we start with you, and then we'll go to Phil.
Great. Thank you, Dr. Burgess. I'd like to do two things today. I have a mic problem.
Pull it close to you.
Not push. Okay. Thank you. I'd like to do two things today. One is to give you an overview of the uninsured, and also to tell you about an innovative program in Nevada called Access to Healthcare Network. But first, newsflash. HHS tells us just a couple of months ago that the uninsured can't pay their hospital bills. Is this news to anybody? And those bills are passed on to all of us. Again, newsflash. Not news. This is just a couple of months ago. So who are the uninsured? And I'll go through this quickly because I think Dr. Burgess, as usual, did a fabulous job of this. The Kaiser Urban Institute has told us that there are 50 million uninsured as of 2009. Just over half of those are under 138% of the federal poverty level. And if you look at my slides, you'll see in the orange section, that's about half. The other half are between 139 and 400% the federal poverty level. Where are the uninsured? Unfortunately, they're in the southern part of our country. They're also scattered throughout. How much does it cost? If you're paying for your own health insurance, so you're not getting it through your employer, how much is it? Well, according again to our friends at Kaiser, just over 10 years ago, it was about $2,000 per individual and about $6,000 for families. Now, it's more than doubled for single and tripled for families. So that means over $5,000 for single coverage and $15,000 for a family. Think about paying that bill a year. So we know who are uninsured. Why do we care that people can't or don't buy insurance? Well, they're less likely to receive preventive care. They're more likely to be hospitalized. They're sicker and they have much higher mortalities. And, hearkening back to good old HHS, our uninsured problem costs all of us more, hospitals, healthcare professionals, and consumers. I love this. I don't know if you can see it on your slide deck, but it's the greatest little note that came out of it's not a note, it's a billboard, a giant billboard that a hospital paid for, and it says, ER wait times you can trust. Are you kidding? This is what hospitals are advertising right now, emergency room wait times. And there's a little note here at the bottom that you can probably see better when you're driving in your car and you see this thing. You can text us to find out what the wait time is at your ER. I think that's pretty sad. But wait a minute. Here comes healthcare reform. Isn't this going to solve all of our problems? Well, let's say we start with 50 million people, and for argument's sake, let's say that they're right when they say about half of those people are going to now be covered under health care reform. Of those roughly 23 million, again according to the Urban Institute, those 23 million, 40% of them are eligible for coverage and not accessing coverage. I remember during health care reform, I went into a meeting with some high-level officials at HHS and told them about what I'm going to tell you about in a minute, this access to health care program in Nevada. And they said to us, what if we put you out of business? And the answer from Sherry Rice, who was the head of Access, the CEO, said, that would be wonderful. Because they're not. Healthcare reform isn't capable of doing that, not in its entirety, and it took about 2 or 3 years for people to start to admit that. So, where are the solutions? We've been wrestling with this issue for decades, especially the last two. I posit that there are solutions. Where? You should look to the states. The problems are complex. The solutions need not be. Think of the state solutions as pieces of a puzzle. Finally, let's talk about access. Access is the only not-for-profit medical discount plan in the United States. It's not health insurance. It's not an entitlement program. It's a public-private partnership. In Nevada, in only 3 short years, Access has helped 11,000 people. 3 years, 11,000 people get comprehensive health care. And Access signed up 1,800 providers to do that. It gets better. The model is self-sustaining. It pays for itself in just 3 years. That's in Reno where it began, and they're expanding it to Las Vegas. Also important about Access to know, and this is a big also, is only 1.5% of Access members go through the emergency room unnecessarily. 1.5%. And I'll tell you how they did that. The way they did this in a nutshell is what they call a shared responsibility model. Sherry's going to kill me for putting her picture up, but I'm going to do it. As Access, as Sherry likes to say, we ask something of everybody and try not to overburden anyone. Who makes it work? Again, I told you it's a public-private partnership, so lots of people make it work. The members make it work because they pay a monthly membership fee. They take the responsibility. If there's a no call or no show to your doctor when you have an appointment set up, you are kicked out of the program. That is made very, very clear when you meet with your caseworker when you come into Access as a member. That's part of the deal. If you don't show up to your doctor's appointment, out. Providers, how they have skin in the game, is that they offer enormous discounts. And I'll tell you what those are in a moment. The community has given a tremendous amount of money through a patient care fund and also through direct care dollars that they contribute. So for example, with these huge discounts, if there's a small amount, it takes less money to cover more people, your donation is going to go a whole lot further. You're going to be able to care for a lot more people. The government programs also put funding into Access because there are some things the government can't cover. By their rules, by their nature, Ryan White is a good example. Access will cover the things they can't cover. Employers, the banking, and the insurance industry are also heavily involved in Access. So it's everybody. It's everybody in the picture of healthcare. Employees can put their employers on Access. The banking industry developed an HSA so people can save money for when that time comes when they need health care. And the insurers have a referral. They have a separate thing to give to people who come in and say, well, I can't afford your insurance. Well, go to Access. Here's in your packets, again, is the shared responsibility depiction, which I think is very useful to take a look at. So who are Access members? How do you get to be a member of Access? You must be currently uninsured. You must be able to show proof of all income, such as a pay stub, income tax form, child support, and other money received from any other source. You have to live in Nevada and show proof of the residency, and that proof can come in the form of a utility bill or a rental agreement, and you must show photo ID. Also incredibly important, and if you look in your packet, there is eligibility income guidelines in this form. So how does it work? Members pay their membership and they show up. Access gets low rates. The members pay in cash. That's right, I said it. They pay in cash at the time of service. Because of Access's excellent work, they have also become the one-stop shop in Nevada for referrals. They have a 1-800 line, and they take all these people together, and Phil will tell you a little bit more about how his group does this as well. But that's what they do. They're so good at it that they're referring everybody to where they need to go, whether it's Access or through government programs. This cartoon recently caught my eye. It says, everyone agrees to help reduce healthcare costs. And the patient says to the doctor, I can't afford the diagnosis. Do you have a cheaper one? Well, that's funny for us. We're laughing at this and thinking about it. In Nevada, that's exactly what's happening. It's exactly what Access does. They find a cheaper diagnosis. So, for example, for an inpatient hospital stay, non-Access members would pay about $50,000. Out of your pocket, right? No, you usually go into debt. $50,000 for a 10-day hospital stay. But Access members pay $3,000. 3 compared to 50, that's a huge discount. A hysterectomy, $20,000 to $45,000 off Access. On Access, $1,800 to $3,500. For a broken ankle, $25,000 to $35,000 in Nevada for a broken ankle. It's a lot of money when you're not uninsured, or when you're uninsured. Access, $1,500 to $2,200. Huge, huge savings. You're probably asking yourself, what doctor in his right mind would offer these kind of discounts? People show up. People come to their appointments. The doctors can give the care, and the hospitals would much rather have somebody paying part of the bill than none of the bill. And as I said earlier, 1,800 doctors think this is a good idea that they signed up just in Reno, Nevada. So, I think this is pretty cool. I happen to be fortunate enough to represent Access to Healthcare Network and Sherry Rice, their CEO, and their fabulous board of directors. And if you don't believe what I'm saying, you can take a look at their recognitions, awards, and distinctions, and their testimonials. And if it's okay with you, I'd like to read a couple of those from one of the providers. I've been most impressed with how Access helps people return to a normal life. Many of my patients basically are non-functional because of a problem they can't afford to have fixed. They can get that problem solved through Access and go on to live a full life. Employers, this is an owner of 15 McDonald's stores. Access provides us with affordable healthcare solution that's simple and easy for us to administer. And with a very diverse workforce of 400 plus, that's saying a lot. From a member, the whole package of Access to Healthcare has given my wife and me new hope. The Access staff, the providers, everyone at Access treats us with respect and care. This has been a truly positive experience. So to summarize, why does Access work? Everyone in the game has skin in the game. They're all giving something and receiving something. Hospitals and doctors took an absolute leap of faith that has paid off in the end. Members are held responsible to the Access rules and fees, and again, they retain their dignity. The care coordinators that work with Access also have learned how to specialize in certain diseases. So you get people who have much more knowledge about who the cancer doctors are or whatever it is that you need. Also, with the enrollment process with members, it has to be face-to-face. So this is a community member who is meeting you, not just on the phone, some random 1-800 number, who is meeting you face-to-face to enroll you in the program. They also got technologically savvy, and they're doing Skype enrollment. So there's still technological face-to-face. They also have an incredible staff and a leader in Sherry Rice. And Sherry likes to say, when we saw a need, we did one more thing. And then we saw another need, and then we did another thing. And we saw another need, and we did another thing. That's how you solve the problem of the uninsured. At least that's how it's working in Nevada. Thank you.
Thanks, Peggy. Phil, why don't we go on with your presentation, and then we'll open up for questions.
Thank you. I'm here representing the Foundation for Health Coverage Education. It's a program, it's a nonprofit that was put together by us out in the Silicon Valley. Our advisory board is Carly Fiorina, Leonard Schaefer, who started WellPoint from scratch, made 32nd largest company in the United States. Dave Helwig, who was the CEO of WellPoint Anthem, and an esteemed professor of economics named Alan Intoven. Oh, you got to start over, sorry. Oh, here we go. I didn't have it on. Starting over. Okay, I'm here representing the Foundation for Health Coverage Education. We're in the Silicon Valley in California. We've put together a very high-tech, low-cost solution to the uninsured problems in the United States. Our board of directors includes Carly Fiorina, who was the CEO of Hewlett-Packard, Leonard Schaefer, who was in part of the Carter administration, but also started WellPoint from scratch, became the 32nd largest company in the United States, Dave Helwig, who ran that company, and Alan Enthoven, an esteemed healthcare economist at Stanford, who was also Undersecretary of Defense. The problem we saw is that a lot of the uninsured are eligible for programs in error. And so what we did is put the entire United States healthcare system online. Over 3 million Americans have used it, and it's been around for a long time. Through the power of technology, FHCE enables people who need health care obtain it. There's 16.9 million Americans who are eligible for publicly funded programs and not signed up. They're using the emergency room as their primary care. They go in the emergency room, they get taken care of, and then they leave. And the emergency room cannot collect because they're not there and they don't have the money to pay anyway. And so, with a mission to provide simplified public and private health insurance eligibility information, the FHCE enables us as a nation to know and control our costs, prevent waste, fraud, and abuse, and allocate the total cost of health care properly and accurately. And we do this because we do eligibility at point of care. So when someone comes into the hospital, it takes 2 minutes. 2 minutes. The whole United States is online, all 50 states and the District of Columbia. The administrator asks the questions. They see what they're eligible for. It can be confirmed online, and then the hospital or doctor gets reimbursed immediately. In California, we have 27,400 employees whose job it is to sign people up for Medicaid, which is called Medi-Cal in California, welfare and food stamps, and all of the eligibility is pretty much the same. It's based on what county you live in and also how much money you make or don't make, your federal poverty level. Those 27,000 employees cost California about $110,000 each per year. That's $3 billion being spent on administration, not one nickel of which goes to health care. With point-of-care reimbursement and point-of-care eligibility, we empower the individual to understand that they have coverage if they're eligible. They no longer need to go to the emergency room for everything. All they simply need to do is show up at a doctor's office or a clinic. It takes 2 minutes to figure out, and then we know what's going on. Once we collect all that data, for the very first time in American history, we're going to be able to budget our health care costs. We're going to know what we're spending money on. We're going to know if all the procedures and everything that are being done are worth it, and will lower immediately the uninsured by 17 million people if they go on this program. Right now we have 50 states trying to create the exchange. The exchange is already done, and we've had it on there for 7 years, and it works and people love it. Hospitals, doctors. In fact, some of our partners are the most prestigious names in healthcare. We have the American Cancer Society, who works with us. They take 1.2 million calls a year from people who just found out they have cancer. And one of the questions they asked is, do you have health insurance? And before they started working with us, they really had no answer. They just said, oh, that's too bad, or maybe we could, But now the American Cancer Society either refers them to our 800 U.S. uninsured helpline, where we answer the phone for people and do it on the phone for the people who don't have access to the internet. And so they're referring anybody who has cancer who's uninsured to us, and we find coverage right away. The American Diabetes Association, heart, lung, blood, all of them refer to us. But then what really was interesting is the hospitals started using it. So now the hospitals, when people come in the emergency room, are doing the 2-minute quiz, and they're seeing for the very first time, not that this person who came in the emergency room was uninsured, but who should have been liable, who didn't pay when they were supposed to pay. In California, at Sharp Hospitals, that's 4 hospitals in San Diego with 4 emergency rooms, over a period of a year, asked 20,000 uninsured patients the eligibility quiz as they came in the emergency room. 80.2% were eligible for public programs and not signed up. 80.2%. Amazingly, 99.7% were eligible for something, and this is before health care reform. So people don't know what they're eligible for. Not all the other people who would have had to buy a plan could afford it. So we do need policy. We do need to confront these issues. But 80.2%. So we called the Medicaid office in San Diego 50 times during working hours. After all, we're spending $3 billion a year in California. They answered the phone 15 times out of 50 times during working hours. 35 times you couldn't leave a message and they didn't answer. The 15 times that they did answer, you had an average time on hold of 22 minutes with the longest time on hold of 48 minutes. $3 billion a year, 80.2% of the people who come in the emergency room, where it costs 5 times what it costs to go to a doctor or clinic, are eligible for these programs and not signed up. It's wrong. With our technology, we can do eligibility at point of service, at point of care. And then you carry that one step further, and we do reimbursement point of care. And all the 17 million people from all across the United States will have health care access. This is 100% already set up. And it's working. Thank you.
I just want to be sure I wrote it down. I'm going to exercise Chairman's prerogative and ask a question of both of you, and then we'll open it up to general questions from the audience. Both of these sound like very, very solid, good ideas. And I forgot my copy of the Patient Protection Affordable Care Act that I usually like to wave around at a point like this. But imagine that I've got a big, thick yellow book in my hand. Why are these programs not included in that law? Was there no room for ideas like this? Were there better ideas that were incorporated? Are there things that are yet to happen that we'll see that will be so great that would negate the purpose of having either of these programs included? Peggy, let me start with you, and then we'll go to you, Phil. What are your thoughts on that?
I think, interestingly enough, there is a provision in healthcare reform for a 10-state, 3-year demonstration for programs that look a lot like Access, but it never got funded. It's incomprehensible to me that something that's so obvious...
Wait, I got to interrupt you. I'm sorry.
Here we go.
It didn't get funded. Everything in the Patient Protection Affordable Care Act was pre-funded by preordained appropriations for 5 years. And this one provision that might have actually helped someone didn't get funded?
You got that right. So it's not going anywhere despite bipartisan support.
Well, again, this is an important point because a lot of people say, well, it didn't get funded. Clearly that's a problem that Congress is just being too parsimonious with money. But the Affordable Care Act literally lavished money on all kinds of programs, some of some worth, some of dubious worth, and yours was not included?
That's correct.
Okay, I'm sorry, go on.
Leonard Schaefer was part of the HHS system during the Carter administration, and he's on my advisory board. So when healthcare reform passed, he actually referred me to Bob Kocher, who's the person who communicated directly with the president in charge of healthcare reform. He referred me to Todd Park, who's the person in charge of technology for all of this, and we showed him what we had online already, and they couldn't believe it. They had no idea it existed. I'd already communicated as much as I could, but it's hard to break through. And for real reasons, it's hard to break through, right? But this time we actually were right there, and they were very surprised to see that the U.S. healthcare system was already online and that millions of Americans were already using it. So I offered to share it with them and share my technology and everything, and but they didn't really want to do that. In fact, they sort of copied it and tried to come out with their own. It's not as good, but you know, what are you going to do? You do the best you can. I mean, we're doing this not for one side or the other. We're doing this to help America. And Americans know it. They're using it every day. We have 125,000 Americans use it last month, right? And so that's how it is. We think we could save the United States somewhere around, once it got implemented, maybe $20 billion a year in administration if they went to point-of-care eligibility throughout the whole country. Yeah.
Well, let me take questions from the audience. I've got a number of things I could ask, but I don't want to monopolize the time. We'll open it up to questions. And Rebecca, anything that you get off the Twitterverse, hand to me. And if you are going to ask a question, I guess we need to use the microphone. While people are collecting their bearings, let me just follow on my initial question. I guess I don't understand what, even without funding, Peggy, what would be the barrier to setting up something like this in other states? Are there other states that have expressed an interest in this?
Yes, Sherry has been talking to several different states, California included, and saying, here's a model, take it, go run with it. How they got started is there was an initial grant to pull this all together. That's the government funding to start. In 10 states, about $2 million could be done for about $1 million. Isn't a lot of money. And then at the end of the day, when you're self-sustaining, that's an investment, the kind of investment I believe that the government should be making in its priorities. I'm fearful that this isn't considered a priority.
Let me ask you this, because, I mean, it comes up all the time from employers' questions to our office. Say you're a big national retailer and you have the largest retail market out there, and you've been criticized a lot for not providing your employees at the entry-level insurance. So you do that. You start providing insurance, and it's a fairly low-dollar policy, and it has some limits. So these limits are no longer allowed under the Affordable Care Act. The lifetime limits on and the out-of-pocket limits that are going to be enforced in 2014 under the Affordable Care Act will negate a lot of these policies. So people have sought waivers in order to continue arguing that some insurance is better than no insurance, and the exchanges themselves don't start till 2014. So the Center for Consumer Information and Insurance Oversight has provided, over the past year, it was about October of last year that they started, they've provided, number is now 15, 16, 1,700 individual waivers. Would your access require a waiver in order to continue?
It would not, because it's not insurance. It is a medical disc plan through the state of Nevada. So those were part of our earlier conversations is, are you going to put us out of business because we don't fit into your model of what would happen in an exchange? And as the leaders at HHS said to us, what if we put you out of business? And again, they wouldn't, because there's still going to be this uninsured population that somebody needs to take care of, and that Access is doing very well.
But it's not affected by the lifetime limits and would not need a waiver in order to continue?
That's correct.
So in theory, it could continue even after, say, the implementation goes off without a hitch. The Supreme Court says all clear by us, and the Affordable Care Act is the law of the land for the rest of my natural lifetime. Your access could continue to function.
That's correct.
The argument would be that it would be unnecessary, but some people might still prefer that if they've had exposure to it before.
Exactly.
Yeah, please go ahead. If not, I'll continue badgering the witnesses.
Did you have an answer to that, Phil? Or
That's right.
Well, let me ask you this, Phil, because I mean, you made mention of some of the administrative costs. Now, we are constantly told that the private insurance companies in this country take too much of the premium dollar for other things, presumably that other things are profits, and so the administrative costs in private insurance is inordinately high, and in fact there is, in the Affordable Care Act, there's going to be a limit on how much of them can be spent on non-clinical issues, the sort of the medical loss ratio rules that will be coming out of Health and Human Services. But you're talking about not the private insurance realm, but you're talking about the public insurance realm, where you maintain that administrative dollars, I hate to use the term wasted, but I'll use that because it perhaps sums up what I heard you saying when you gave your presentation. So how do you keep these administrative costs low in your world?
Well, you know, one of the things that they did when they tried to figure out the administrative cost of, let's say, group insurance and then small group insurance was include the broker and marketing costs in the cost of the insurance company.
Right.
But in reality, the insurance company never received that money. They received it, but it went right out. The day they get it, I mean, they don't have that money. And really, it is the person buying the insurance, the group, that's paying that commission to the broker, and the broker does all kinds of services and advocates for all of the people that are under that group. So it could be the dependents or the spouse or the employee or the employer. And there's a whole lot of laws and accounting and everything that brokers do. So when they included that in the minimum loss ratio, it really threw everything off. Insurance companies generally work only on 3 to 5% as total profit, health insurance companies. And a lot of people think, oh, they must be making 25% or something, but they're not. And so they could cut their profits in half, and still, within 3 or 4 months, just by medical inflation, you'd catch it, right? And so the whole concept of minimum loss ratio should scare anybody in any industry in America, because the health insurance industry is an industry like any industry. It has competition, it's tough, and it's a very complicated business. So if they're going to start telling them how much money they can make and how to run their companies, it won't be long before they start telling everybody else.
Well, on one of your bullet points here on the handout that I have, is that the foundation could save the country $25 billion a year on health care administration. And we're already told that Medicare is, as far as the administrative fees, are only like 3%. I actually would dispute that figure, but let's stipulate that that's the case. How is the foundation going to save additional monies there?
Well, I'm using California as an example. If we did point-of-care eligibility and point-of-care reimbursement, then the patient is out of the picture for having to sign up for all this. And if you think about it, and one of the biggest problems with what, as I see it, with healthcare reform is that they've confused health insurance with health care. Mm-hmm. And so all of the programs that are public programs are really prepaid health care, right? It's not insurance. You're not evaluating risk. You're not trying to do anything except for give access to health care for the safety net, which we need. We all believe in that. But the thing is, they've created this huge barrier of entry for let's say, a single woman with two children at home to have to go down there and get signed up, and then they can never do it in one try, and then she has to go back, but she's working, and now it's a huge problem. Why are we making her go through that?
And how does the foundation cut through some of that?
We have the whole United States healthcare system online for all 50
Wait a minute. The whole United States healthcare system online?
Sure. It's at coverageforall.org. And you go on there, take the eligibility quiz. It takes 2 minutes, and you'll see what you're eligible for. It will give you a copy of the application you need to take. It'll give what you need to take with you to get signed up. Let's say for something like Medicaid, you might need to take your PG&E bill, a copy of your last paycheck, and all that. So we're trying to make it so they can get it all done at one time, right? But still, it's really difficult to get signed up. In California, they're only allowed to sign up 2 people a day per person. So they have a limit on the amount of people that each person can sign up. In California, of course.
Each person in the Medicaid office?
Yeah, and that's because California's in, financial trouble. But the thing is, so you can't just not sign them up, because all that does is transfer the cost to the private sector, because the hospital has to charge somebody. Mm-hmm. And that's why the premiums go up, right? And then that creates this cycle. But it makes the insurance companies look like they're the bad guys, yet they're only working on 3 or 4% profit margin, right? And so there's a whole lot of waste in the system. Now, the whole concept of the exchanges, that's like 1990s technology. That would be like investing in Xerox 820 computers, desktops, with 8-inch floppy disk drives. And we have the whole country investing billions of dollars, each state doing it separately, in these exchanges. And yet you could set up the exchange, like for instance, our system's available on your iPhone. It's called Got Coverage. And it's all done anonymously. And there's no selling of anything. But all we want to do is make sure everybody understands what they're eligible for. Or your iPad, right? And so that's all on there. All you have to do is do that, It takes 2 minutes. It'll show you what you're eligible for. You know, it's simple. It's so simple, it's scary.
I've got some other questions I want to ask you about that, but let's take a question from Roddy.
I was just wondering, you said that in Nevada, this program is not considered... Is this on?
I'll repeat the question, but go ahead.
Okay. It's not considered health insurance. So does that mean those people signed up for that would still pay a penalty for not having insurance?
The question was if it's not insurance, what Access is offering, and it's not, it's a medical discount plan. Under the new regime of healthcare reform in PPACA, if you don't have insurance, you have to pay a penalty. When we went in and had the conversation about that, because we're not insurance, the answer we got from HHS was you wouldn't be affected. You would not be dinged for that. How that's going to play out in a regulatory sense is anybody's guess.
Wait a minute. Wait a minute.
I don't make
If you're not
this stuff up.
insurance, then how can someone use you as insurance?
I'm not making this up. Really.
Does the IRS know about
I don't
this?
have any assurances right now to know that that's how it's going to work. I am hopeful, and we continue to talk to the administration and frankly plead and beg that those people who are actually getting it done in a really smart way that really works for them will not be financially penalized by how the system's going to work out. I don't know the answer. I wish I did.
So it will be judged as credible coverage under the Affordable Care Act?
It's not credible coverage because it's not coverage. It's not insurance. So I don't know if one of those 17,000 waivers is coming our way, but I hope that those assurances we got is that they're not going to hurt us.
Well, I think HHS is out of the waiver business, is my understanding.
Lately.
Other questions from the audience or from Twitter? If not, I've just got to ask you this, Phil. I mean, states, and you referenced California as having some trouble with paying for what their obligations are. And the Medicaid population is going to increase by, pick a number, but probably around 15 million is a pretty safe guess, with the coverage of more and more adults under what should have been a safety net program in Medicaid now will become primary insurance for anyone who earns under 138% of the federal poverty level. So how are the states, I mean, the states are obviously going to be concerned about a group such as yours that's finding more and more people that should be covered under Medicaid. Is this a problem for the states for the future? I mean, I understand it's going to be a problem because we've added so many newly eligible people on the Medicaid rolls, but you say they're not already they're not taking care of what they should be taking care of, and your point of service engine that will then drive people to the coverage that they actually should have, and then we're adding 15 million more people on the Medicaid rolls. It looks like a tremendous burden for the states.
Well, that's one way of looking at it, but if you think about it, it's a zero-sum game, because the 15 million people are already using the emergency room as their primary care, right? And they're not paying. And so we're paying anyway, right? So it's not going to be all of a sudden more money. And in fact, it should be less money, because if the 15 million people who are eligible and not signed up understand that they can go to the doctor or clinic without having to worry about, paying for it, or at least being covered through a government program, perhaps that person that's let's say having symptoms of diabetes is going to go early and then get it under control rather than showing up at the emergency room when they have an infection or something like that and they need an amputation. And so I don't see this as costing us more. What we see it as is fully understanding exactly where we are. It's the very beginning of getting it under control. You can't go somewhere unless you know where you are, right? And so if we get everybody signed up, then we're going to collect the data. We'll have all the data, and we'll know what we're spending our money on. And like I said before, it'll be the first time in American history that we can actually budget in the United States. If the states paid more, for all the people that were eligible that they're supposed to be paying for, theoretically, the cost of insurance for the premium payers should go down. But for us, that's not really the issue. We want all Americans to have health care access. If we have a program that is passed by law and that person's eligible, they should be able to use it. It shouldn't be sort of hide and seek. Let's make a law that makes us feel good, and then let's not let anybody use it. And we'll put a big, giant bureaucracy in the middle. in order to sort of control what our budget is, right? We want to know exactly what it really is. We want to make it accountable, and then we can do cost containment, we can do waste, fraud, and abuse control, and we're going to provide access to all Americans for health care.
Yeah, we'll come back to that waste, fraud, and abuse, but let me just ask if there's... wait, let's go to the way back there first.
Hello?
I'll repeat it too.
Okay. Hi. I had a question about coverage for all. You mentioned that it's sort of similar to what the health exchanges are going to do, but it's better. I was wondering how the health exchanges are going to affect your program in California.
Well, our program is actually... she was asking how the health exchanges are going to affect our program. I'm kind of like the person who runs yours. If we got put out of business, that would be great, if it made sense. What we do is our mission is to lower the ranks of the uninsured throughout the whole United States. That's why we put this whole thing together. But by bringing it all together for the very first time, people didn't have to know the program existed. That's the key, actually. The 5 questions is an algorithm that the five questions, it pulls up the program you're eligible for. You don't have to look at 5,000 programs, right? And so that's the beauty of it. And then it pulls up the application. And that's just a really simple thing. It's very hard to do, but it's a very simple concept. And so I think California would be, and they already use it in the Employment Development Department of California. We get referred by the Department of Insurance. Anybody who calls them and says, I don't have insurance, what can I do? They refer to us, as well as Ohio, Louisiana, and other states. It's really amazing. In our annual report, we have a funnel. And what's happened here, if you think about it, the people who need health care are the people who are either sick or injured. The rest of the people don't need it right now, so they don't really think about it. That's why I think a lot of people don't sign up. And what we've done is with this funnel is through the American Cancer Society and diabetes and heart and lung, the hospitals, the departments of insurance, the employment development departments, all of these people refer to us, and all the people who have pre-existing conditions or are sick are finding out what they're eligible for, and they're able to go and use it right now. And so it's a beautiful thing. And by the way, this happened all on its own. We set it up. We had no idea it was going to have this kind of demand. There was a big vacuum for this information. And it just keeps driving us and driving us. And there's lots of things I'd rather do. But this is so important to the country. And there's so much consumer demand. And we get so many wonderful letters and phone calls and everything from people saying, oh, you saved my life. I had no idea that I could do this. And that we see it as a gift, as something we can do. It's a private sector, nonprofit, anonymous program, but it helps millions of Americans. And if you go to coverageforall.org, you can see it there. It's all laid out, all of our finances, everybody who's, and all that sort of thing. And so that's what drives us, really. We want to help.
If we can do so under the limits of House ethics rules, Rebecca, if we could put a link to both the access and to the coverage for all on the Health Caucus website, people might find that interesting. Now, if somebody wanted to know, for example, the 5 questions that you ask when someone comes in the emergency room, they'd be able to find that off your website?
They would. And if anybody out there knows somebody who doesn't have health insurance, just send them there. And they don't have health care access, send them there. They'll find it.
This is states other than California?
Oh, no, it's all 50 states.
All 50
District of Columbia. And it's been up and running a long time. It's coverageforall.org. And then the 800 numbers, the 8 is the U.S. Uninsured Helpline, 1-800-234-1317. We have 32 operators who are all trained, answering the phone 24 hours a day. They speak 190 languages. So that's because we have a service, really. They don't really speak 190. But we can answer the phone in 190 languages.
Okay. And just to be clear, access is only for Nevada. Is that correct?
Access at this time is only for Nevada. They'd like to teach others how to do exactly what they're doing. And the beauty of, I think, Phil's program and our program is that there's a lot of different ways to do this. There isn't one answer. We know that there are models that work, and why aren't we looking to those models that work and using them all over?
Very good. We had another question.
I just Wondering if the emergency room is also considered a point of care?
It is a point of care, yes.
Question was, is the
She's
emergency room a
asking
point
if
of
the
care?
emergency room is considered a point of care. The answer to that's yes. The hospitals, the doctors, all services are point of care. The emergency room is a very expensive center for point of care.
Application right there.
Oh, it's online. And we actually, when a hospital decides to use our system, we integrate it into it becomes theirs. We stay on top of all of the programs throughout the whole United States. If they change Medicaid or they change an S-chip plan in one state, we just change it and it gets done. So we've centralized all that information, right, so that they don't have to. And the hospital can use our system. It's very inexpensive. Yeah, it's been very successful.
The beauty of this, again, is that what Access does is they're trying to keep people, and they do it very well, keep people out of the emergency room, again, at 1.5%. It sounds like what Phil's group does is that's where they catch them, and then they try to prevent them. So, again, good ideas from a couple different places.
Right, and I would say your idea is more on controlling costs, which is exactly what we want to do as a country, right? Until we know who's in the programs, we can't control costs because they're not there.
Oh, yes, we can. We'll only answer 2 of your Medicaid questions in the course of a 24-hour period.
Well, yeah, that's one way. And we can transfer the costs, somewhere else. But don't you think, as a country, we should know exactly where we are? And let's be honest with ourselves and not fight over this and that. And and then as we fight, people are not having access to care. We want to give everyone access. We want our programs to work, right? This is a great country we're in, and people need to know that. They need to know that we can figure this out, and we will, and it's working, and we're getting there.
Well, I got to tell you, I'm so impressed listening to both of you. I can think of times within my practice lifetime, Peggy, where I'd have someone come in, and even if I said, okay, you need this done, I won't charge you, but then you were always up against the hospital, and you were up against the anesthesiologist, the pathologist, and a way to access that with one phone call as opposed to, it's like I got punished twice. I wasn't going to get paid for the procedure, and I also had to go in and organize and orchestrate all of these other ancillary activities that would surround that person's hospitalization. And I just got to tell you, I never once, I worked at a hospital that was a private hospital and known primarily by its initials, and they would never give anyone a break. So this is an exciting transformation, an exciting difference, and certainly for the person who comes in, recognizes they have a problem, semi-elective, but I want to take care of it in the right way. This is an opportunity for them to do that if they live in the state of Nevada, and I hope it is replicated in other areas. And then Phil, in your instance, I just can't tell you the number of times that I did a delivery at 2 o'clock in the morning on a Saturday morning. The patient would be long gone from the hospital by the time the social worker arrived at 9 o'clock on Monday. So as far as verifying any sort of, even if it was an emergency Medicaid that this patient for which they might be eligible, the person who could sign them up was long gone by the time, or the patient was long gone by the time the person arrived at the hospital. So the actual point of contact, I mean, your system works 24 hours a day, 7 days a week, I assume. Is that correct?
Right.
So that that in and of itself would be a game changer for, I practiced in Texas, I practiced OB-GYN. I was not close to the southern border, but nevertheless, we had a number of people every week, every weekend that came in and sought services who didn't have a Social Security number, but might be eligible for emergency Medicaid under a federal program. But then they were lost to the four winds because the address they gave was frequently incorrect and contact information was less than accurate. But the way to verify when they immediately came in to access the coverage for the physician who rendered the service, that's such a tremendous step forward, and it's utilizing things that are already there. You haven't had to build any new infrastructure. And then I was really struck by your comments of why in the world did if we said we're going to go in and restructure healthcare in this country from soup to nuts, top to bottom, why did we go back and recreate 1950s and 1960s programs surely we could be smarter than that. And that's what I like so much about what you've articulated here today. There was a way to be smarter than that. There is a way to be smarter than that. So regardless of what happens with the Affordable Care Act for the future, regardless of its fates in the court, these type of concepts that both of you have brought to us today are ones that are worthy of study, worthy of recognition, and implementation at some place, either in the Affordable Care Act or the brave new world that follows its demise in the courts. So thank you both for being with us, and as always, Health Caucus will keep this webcast up in perpetuity on the website. So if you know someone who really would have benefited, perhaps someone that you know who would have benefited from one of these programs, the contact information, if it comports with the rules of House Ethics, will be available on the Health Caucus website. Thank you all for your attendance today.
Thank you.